Hey there, this is Tracy Bracken, nurse practitioner with Blunt Senior Care Partners. This YouTube video is going to be talking about the infection control strategies that we learned at our Long-Term Care Coalition meeting on December 10th. The objectives for the presentation, which actually is only about 20 minutes, is to discuss common pathogens, specifically influenza virus, norovirus, and C. diff, which are pretty common pathogens that we find in skilled and long-term care areas. We're going to talk about different forms of isolation and why we would choose one type of isolation over another. We would also talk about ways to empower our staff so that they can educate the patients and family members in hopes to prevent the spread of disease. We'll talk about different surveillance mechanisms, things that we need to collect, things that we need to document, things that we need to review and trend so that we can be good infection preventionists. Also review pertinent guidelines and the information that we obtained in this presentation. We looked at the CDC guidelines, and there are certainly some excellent resources on the State of Tennessee website. We also have organizations like APIC, or the Association of Professionals in Infection Control, and places like the Healthcare Infection Control Practices Advisory Committee. Finally, we'll talk about different resources for further guidance. If we get stuck on a certain pathogen, ways that we can help prevent the spread of disease, and different people that we can go to. Because actually, infection control is very difficult, and now that we have multi-drug resistant organisms, and in skilled and long-term care areas where we have elder persons that are immunocompromised living in close quarters, it's imperative that we're up to date on our infection control practices so that we can prevent the spread of disease and take excellent care of our patients. Before we get into talking about the pathogens and the types of isolation, we'll do a brief history of infection control. And you can't speak to a group of nurses without talking about Florence Nightingale, who was the first infection preventionist, and she did most of her work in the Crimean War in the 1850s. She actually found deplorable conditions for the soldiers and found that mortality rate dramatically decreased when she cleaned up the environment and initiated a hand-washing protocol. Dr. Ignaz Semmelweis, who was known as the savior of mothers, actually also instituted a similar hand-washing protocol. He found a common theme in an increased mortality rate of the mothers in the birthing ward. Actually, the mortality rate was 10 to 35%. After trying to figure out why this was happening, I think he was onto something when he noticed the medical residents who would come out of the morgue after performing an autopsy would go straight to the birthing ward without washing their hands and deliver a baby. So after institution of a hand-washing protocol, we found that the mortality rate dropped dramatically down to 1%. There's Joseph Lister, who was a British surgeon and pioneered the antiseptic procedures in surgery. He started sterilizing his surgical instruments with phenol and found that there was a dramatic decrease in the mortality rate after surgery. And actually, these people worked in periods of time where medical providers and physicians took pride in the stains that were on their smocks or on their lab coats. We found that the dirtier their lab coats were, the more experience they had and the more procedures they performed. And then finally, there's Alexander Fleming, who, this is probably my favorite story in medicine, accidentally discovered penicillin. He was actually studying the Staphylococcus species when he went on vacation, and he stacked his petri dishes up in the corner of his laboratory. So when he came back from vacation, he found that there was a mold growing on them, and incidentally, that mold had killed off the Staphylococcus species. So he was able to isolate that mold, and now magically, thank you, Alexander Fleming, we have penicillin. So the first pathogen we'll talk about is the influenza virus. These statistics that you see below were compiled from APIC, or the Association of Professionals in Infection Control. Certainly, these are astounding statistics, and if you look at a pathogen that is responsible for 3.1 million days of hospitalization and 31.4 million outpatient visits, we tend to want to pay attention to that so that we can control that spread of disease. When we talk about the modes of transmission for influenza, this information was obtained from the CDC website. You can actually spread these droplets from up to 6 feet away. So on the previous slide, you saw a picture of this man sneezing, and I put that in there because I was extremely impressed with the trajectory of his sneeze. So, of course, you can tell how easily droplets can be transmitted from one person to the next. They can actually land on our nose or our mouth and be inhaled by our lungs. You can actually get the influenza virus from touching a surface that has the virus on it. Symptoms of the flu usually manifest themselves 1 to 4 days after the virus enters the body, but you can actually pass that virus along even before you know that you're sick. When we talk about prevention and lines of defense for influenza, certainly we want to talk about getting your flu shot, being vaccinated annually, and I hope that we've already had discussion with our staff members, with patients, with families, with people out in the community. That's certainly our first line of defense when we talk about the spread of pathogens. We need to be vaccinated. Then certainly education. We talk about education with the flu shot, and often we hear things like, the flu shot gave me the flu, or something like that. So we need to be well prepared in talking about being able to get our flu shot, but we need to talk about appropriate hand washing techniques and trying to stay away from loved ones or friends who have been exposed to the flu. And then certainly we would talk about chemoprophylaxis, which typically is Tamiflu. You do 75 milligrams daily for 5 days, but actually there's, for 7 days. But actually there's literature in the long-term care areas. You'd actually do Tamiflu prophylaxis for a minimum of 2 weeks, or that is until 1 week after the last known case of influenza. As with any of these pathogens that we're going to talk about today, prevention is important. However, early identification and rapid containment is going to be a common thing that you're going to see with all the pathogens. So we need to be looking for signs and symptoms of patients that may have the flu, and then go ahead and start trending that data, and then contain these things as rapidly as we can. I hope that most of our facilities have signage that talk about, if you're sick, families or visitors, it's not a good idea to enter this facility. And certainly if we notice that family members or visitors are showing signs or symptoms of the flu, that we need to be intervening and ever so nicely but diligently asking them to leave. When we talk about treatment for influenza, certainly supportive care is very important with our elder population. These patients might get fluid volume depleted. They might get a superinfection such as pneumonia. And then treatment would also include things like Tamiflu. If they actually have the flu, would be 75 milligrams twice daily for 5 days. We've previously prescribed things like amantadine, but actually it's not really recommended in influenza A because we've seen resistance in that. Norovirus, or also affectionately known as viral gastroenteritis, is spread by way of vomit or feces. And this can be spread by way of person-to-person contact, handshakes or hugs or whatever. And then, of course, contaminated objects, contaminated food or drink, and can actually be aerosolized when people vomit. The incubation period for norovirus is roughly 12 to 48 hours. As with all the other pathogens, we would talk about prevention and lines of defense. Certainly in this instance, we would talk about hand washing before and after patient care, before and after the bathroom, all the different times that we would wash our hands, and be diligent in holding people accountable to that. Certainly, early identification and rapid containment is a big deal, as with all the other pathogens. So if we see a common trend or a common theme with patients that are in close proximity to one another, all experiencing nausea, vomiting, diarrhea, and we need to get a handle on that quickly and contain it to prevent that spread. For treatment, we would obviously do supportive care. These patients have a risk of also becoming fluid volume depleted, so we would be monitoring their fluid status. Giving them antiemetics, Phenergan, Zofran. There's actually, norovirus can be detected by PCR testing, but actually that's not done very frequently. We would just treat with supportive care and look for clinical signs and symptoms for a diagnosis of viral gastroenteritis. The next pathogen that we would talk about is Clostridium difficile. Its mode of transmission is, of course, by fecal-oral route. So very similar to the norovirus or viral gastroenteritis. Is the same thing. However, we also need to consider that you don't even need to have person-to-person contact or contaminated surfaces to have C. diff. Actually, this is also known as antibiotic-associated diarrhea. That's a little more aggressive than just the regular diarrhea that you would have from antibiotics. This can actually cause pseudomembranous colitis and become quite dangerous, especially for elder persons. Prevention and lines of defense. Of course, we're going to be talking about being good stewards of our antibiotics. So when we talk about identifying infection and treating with the appropriate antibiotic, we need to be thinking about, truly, is the patient having signs or symptoms of an infection? Any type of infection, urinary tract infection, respiratory infection, and we need to be very judicious with our antibiotic use. I've been to different conferences where we talk about there was a resistant strain of C. diff that was in Europe. The way that the health ministry headed this off was to tell the physicians that they are no longer allowed to prescribe certain types of antibiotics. Actually, I believe they eliminated some fluoroquinolones and a group of cephalosporins. And once they did that, they saw their infection rate dramatically decrease. So there are certain types of antibiotics that, of course, have a greater propensity to cause C. diff. But to some extent, they all have propensity to cause C. diff colitis. When we talk about early identification and rapid containment, we need to be asking questions such as, have you had any recent antibiotic use? Because one can contract C. diff even up to 3 months after they finished a course of antibiotic therapy. We would also need to be asking if any close contacts, relatives, loved ones have C. diff infection. And then if this becomes an issue and several people on the same unit in your skilled or long-term care facility have C. diff, this needs to be quickly identified and contained. This may include cohorting or even hopefully not, or even a quarantine. Treatment for C. diff obviously would be, depending on the severity of their disease, mild, moderate, severe. The Infectious Disease Society of America has different guidelines depending on how many stools per day they have. Other clinical features regarding lactic acidosis, their white blood cell count, any sort of bandemia. They would be PO, flagyl, oral vancomycin. There are other medications such as Difficile, but we found that with Difficile, the new studies that are out show that it's more effective if it's given earlier on in the disease process. However, it's very expensive. So many providers are very reluctant to prescribe this when you can get flagyl that's not very expensive at all. And of course, if this becomes a recurrent issue and the patient probably has a life-threatening case of C. diff, then you would then consider probably fecal transplantation. We'll talk about the different types of isolation. There's 3 different types we're going to talk about, or specifically we'll talk about contact isolation, droplet isolation, and enteric precautions. So with contact isolation, of course, we would consider this for our multi-drug resistant organisms such as MRSA or VRE. We would consider this for stool infections other than C. diff, such as Shigella, hepatitis A, Salmonella. And then we would need to be thinking about this type of isolation for patients that have scabies or lice. And then, of course, there's always the question, when do we discontinue isolation? We obviously, this is an individual process with each patient, but consider their clinical symptoms. And then, of course, If the patient has lice or scabies, we would need to consider discontinuation of isolation 24 to 48 hours after the initial treatment for their lice or scabies. When we talk about droplet isolation, the only difference between droplet isolation and contact isolation regarding personal protective equipment would be a mask. If you have contact isolation, you would certainly consider a gown and gloves, but droplet isolation, of course, includes wearing a mask. We would consider droplet isolation for influenza. We would also think about antibiotic-resistant pneumonia and strep pneumonia, MRSA pneumonia, or other bacteria and viruses that are spread by droplet transmission. And finally, for enteric isolation, differences between contact droplet and enteric is that with the droplet isolation and with contact isolation, you can use alcohol hand sanitizer, of course, upon entering the room, after you leave the room. However, with enteric isolation, which is used for patients who have C. diff, or a patient with norovirus, viral gastroenteritis, then we certainly need to wash our hands with soap and water because the alcohol hand sanitizer don't kill the spores. It doesn't kill the spores that are with C. diff. So I hope you don't mind my funny pictures regarding enteric isolation. But if you'll look down here in the lower left-hand corner, you can see a very angry colon, and that's a manifestation of pseudomembranous colitis from C. diff-associated diarrhea. When we talk about surveillance or early identification and rapid containment, we, of course, as healthcare providers need to be aware of the different types of things that are happening in our community. You know, is there a GI bug going around, or what's the newest upper respiratory infection that people are getting? So that way we can be aware of the things that are being passed along in our community so we could watch a little more closely in our skilled and long-term care areas. We would need to think about 2 or more patients with similar symptoms. At that point, you would likely start active daily surveillance. And this can be done by staff nurses, but this also really needs to include clinical mentors, patient care coordinators, nursing administration. You know, anybody who works in our skilled facility needs to be educated regarding signs and symptoms of different pathogens. If you work in dietary, if you work in housekeeping, it's everybody's job to be suspicious for certain pathogens that are being passed around. We all play a huge part in making sure our patients get good care. So if 2 or more patients have similar symptoms, you would go ahead and start daily active surveillance. What is the symptom? When was the onset? How frequently does it happen? Who all are affected? And hopefully each of the facilities have a surveillance log and have educated the nursing staff on how to use that. We would actually carry this out 1 week after the last confirmed case of whatever pathogen you are considering. And then obviously, we've got to notify the administration, notify the medical director anytime an outbreak is suspected or confirmed. And then, of course, hopefully you have outbreak or quarantine protocols that you really need to be keenly aware of. And then at that point in time, we need to really be looking at our new admissions and always be watching visitors. If visitors are showing signs or symptoms of flu or nausea, vomiting, or they appear to be sick, it's okay to kindly ask them to leave. But the staff need to be empowered to do these things. So if as a facility you want to talk with your staff and mention maybe some scripting, because it's difficult to talk with patients, families. You know, we're asking them. It would probably be better if you called rather than came up here. I know you look really sick. But that's difficult for some staff members to do. So maybe provide some scripting for them, things to let them know it's okay to say to family members if they come up and we suspect that they're not well. If indeed an outbreak does occur, then obviously we need to stop communal activities. We don't need to be in the day room or socializing with the different residents. We need to, as best as we can, try to get the patients back into their rooms and notify families, restrict visitation. We really need to be thinking about the types of staff members that are on the floor, and if they're non-essential, we probably need to talk with them about not working that day or working elsewhere. We need to avoid one staff member working in an area where an outbreak is suspected and then going to another area to work. We need to consider if a staff member is in that area where the outbreak is suspected, then they need to stay in that area. They don't need to float and risk transmitting that pathogen to other areas of the facility where outbreak is not suspected. Obviously, we need to notify the medical director and health department. And it would be a really good idea to consider calling your neighboring facilities. We're all in this together to take care of the elder persons in our community. So consider calling other places and saying, hey, we've really got the influenza virus in our facility. Just step up your game a little with infection control practices because it may be headed your way. Again, we're all trying to work together in this, and it's very difficult. And great communication with different facilities will help make us better infection preventionists. We need to, of course, continue our surveillance, gathering our data, because it really depends on when we stop our quarantine as to when the symptoms stopped for these different patients. So think about this, and of course, try to avoid outside transfers if you can to different facilities. Certainly, if this has to be the case, then we obviously need to call that facility and let them know before the patient leaves our facility that they are being transferred from an area where an outbreak is suspected or confirmed. When we talk about different resources, obviously, your medical director is a huge wealth of information. If they happen not to know the answer right off the top of their head, they've got several resources that they can call. Again, a lot of the information from this presentation was adapted from the CDC website. Also, APIC, which I mentioned was the Association of Professionals in Infection Control and Healthcare Infection Control Practices Advisory Committee. The CMS website has some resources, and obviously the state of Tennessee website actually has a really good resource regarding the rapid containment and early identification of norovirus or viral gastroenteritis. So on the email that you'll receive this link to, there's also my personal email, so if you have further questions, I'm happy to hear from you. If you happen not to get that, my email address is tlbracken, BRACKIN, @charter.net. And if you have further questions as well, Dr. Teresa Catron is a fabulous resource and can provide lots of information from different societies or committees aside from the ones that I have listed here. So if you have further questions, email me. Otherwise, go out and disseminate this information, talk with your staff, empower them to be able to talk with patients and families, and hopefully we can prevent the spread of disease and help take excellent care of our patients. Thanks.